Hi, I'm Elvina Gountouna. I'm going to talk to you about Taekwondo. Thank you for that wonderful introduction, Rob. For the follow. Also, I was meant to give a talk with Harrison, the program lead, but unfortunately couldn't be here today. So I'll try to her part of the slides. So just a really quick background on Taekwondo. We were started as part of the citizen deal with of Scotland. We are part of the bigger innovation social care hub. It's a long way to say it. We are a data service, a secure data service. Probably important to point out, which aims to enable health and well-being improvements in the region and beyond. We focus on bringing together routinely collected health data with social care data. That's been more of a challenge. I'll talk about that later.
Stand a bit nearer to the microphone.
Yeah, is that all right here?
That's better.
Okay, good. Where was I? Okay, so we work with data experts of all kinds. We have a lot of interest in data quality, data understanding, and improving both of those things so we can provide safe access to said data for academics, clinical practitioners, and innovation. Support the triple helix that's already, I think, being mentioned. We are very interested in transparency. It's fundamental to everything we do. We are always keenly aware that we're accountable to the public for what we do with data and why. For people who are interested in using our service, we have a website listed there. Very briefly, for a rather longer involved process, there is an application form and people need to fill in. There is a metadata catalog that you can peruse and have a look and see what kind of data might be accessible. We have an email that I would strongly suggest you use at the earliest opportunity if you're interested in using our service, because we can help guide you through the whole thing. It can be quite daunting for first-time applicants. Once the application is submitted, there's a number of steps. There are internal reviews, there are independent reviews, both ethics. We have a public reference group, members of the public, and everything that we do goes through their eyes first. Once everything is approved, our analysts would create your data extract, de-identified, and put it in a secure space where you would be able to do some analysis on it. We always keep the 5 safes framework in mind in our work. If you're not familiar with it, it's presented here as a series of 5 questions. In my head, it's more like 5 interlocking and overlapping safety nets or security locks that allows us to minimize risk because we're always aware that this is sensitive patient information that we are dealing with here. That never leaves our minds, really. Having said that, we try to streamline the process. That can be quite complicated. It's still perhaps longer than people new to working with routine health data might expect. However, we do our best to always try and improve upon that. We curate data sets from different sources. We try and bring it all together, link it. Our approach and how we see data is looking at the entire patient journey. That has both a temporal dimension, if you like, and also looking at it from different perspectives. I'm going to talk a bit more about that later. We do try to also integrate social care. I think this is especially important for things like mental health research. This has been a challenge for a number of reasons, but I'm hopeful that we are making real progress, and I will be able to say something about that soon. I can't stress enough how important it is to us to work with other people, and this is a team sport. No one can do it on their own. We are always very keen to talk to all kinds of people involved in health and health research, whether it is in terms of service improvement, service management, academic research, innovation. It takes a lot of different perspectives, types of skills and experiences in order to do this well. We are guided by the FAIR principles. I'm personally a big fan of that. If you are familiar with it, it stands for findable, accessible, interoperable, and reusable, which means, in essence, we want to make data easy to find and use. So what kind of data are we talking about? You can see what's available on our catalog that's accessible through our website. Very briefly, you would be able to see there information on people's conditions, all kinds of prescribing, GP visits, hospital visits, different types of outcomes. We've done a lot of work to try and combine information from different sources and clean up for things that are universally useful, like common risk factors and demographics, to be able to use that for analysis. Having said that, it's still difficult. It's still messy. This data isn't collected primarily for analysis. It's collected for patient care, and that shows once you start to look at it. There are variant levels of missingness. There are systems being used in different ways than perhaps they were envisioned by the people who built them. It is really hard to know that without actually talking to the people who use them day to day. Data are coded in different ways. There are many different standards. There's ICD, there's DMND, there's lots of acronyms involved. Things are stamped in detail often, however, it can be quite difficult to figure out how they all kind of fit together. For mental health, again, especially important, things are often hiding in free text. That makes it hard to extract for analysis for a couple of different reasons. One is it's just difficult to get all the information. The other is you'll need to be really careful because a lot of the disclosive information in there. There is people's names. There is perhaps details that are not immediately obvious why, but they might be pointers to someone's identity if they talk about their profession or about their family relationships. There's so many different things that we need to think about if we were to give out free text. Furthermore, data is siloed. It's fragmented across different systems. People are often shocked to find that it's not always easy for practitioners to see what's going on in other systems. So if you're a GP, it's not always straightforward to see what happened in the hospital and vice versa. And then finally, even if you know exactly what you want, it can be difficult to find. For instance, it's often a needle in a haystack effect because there's so much of it. And things are not always named in intuitive ways. Well, not to deny them, it's not all bad. We do have some good understanding for a lot of these data sets, and we do work with people who also understand them. We are keen to work more with people who are interested in both research and have a clinical role or clinical experience.
Elvina, 1 minute. Sorry to interrupt. 1 minute.
Okay, thank you. So this is a rather contrived representative journey for a mental health patient from beginning to end, let's say. Things in red boxes are things that are already visible in data, accessible through data log. Things that are have a pink outline are things that are not so easy to get at, and we're working on doing natural language processing to extract this information, as Rob said, so that can be used. I also want to point out the value of linked data because often it is hard to see things just from one source. So when you try combining things from, say, GP and hospital and prescribers, you get a much fuller picture of what might be happening. And to finish, I think that's me out of time. It is a complex picture, a complex system, and being able to link things together and structure in some way that makes analysis possible is quite important, and that is what we try to do, hopefully with the help of other people wanting to use data to improve health and social care. Thank you very much.